Okay, let's unpack this. We are diving into the body's ultimate high-stakes response system, the fight-or-flight mode. This is all governed by the sympathetic nervous system, or SNS. And when a patient is crashing like in shock or cardiac arrest, maybe severe hypotension, we often medically hijack that adrenaline system. We use some of the most potent drugs available to do it.
That's exactly right. And that's why this deep dive is so critical. Our source material here, it's focusing on adrenergic drugs, sometimes called sympathomimetics. It shows us exactly how we can sort of command these involuntary, these autonomic functions. So our mission today, really get instant clarity on, well, three things.
Three things.
Yeah. The receptor map, where these drugs actually work. Then the high-stakes game of dose selectivity, because it matters a lot. And finally, the non-negotiable safety measures, the things you absolutely have to do when giving these life-saving agents.
Right. We're going straight to the core then. We know adrenergics mimic the body's own stuff, like norepinephrine, epinephrine, dopamine, those endogenous catecholamines. But where do they actually, land? Let's map those receptor targets, because where a drug binds dictates everything, doesn't it?
Yeah.
Whether the patient constricts or relaxes, basically.
Exactly. Think of it like two main families, alpha and beta receptors. Alpha receptors, especially alpha-1, these are mostly on the poststamptic cells, the effector cells. They're the ones causing that widespread vasoconstriction, tightening blood vessels out in the periphery. And that gives you your immediate blood pressure boost and some CNS stimulation too.
Okay, alpha for constriction, and beta, that's heart and lungs territory, right?
Pretty much. Beta-1 receptors are primarily in the heart. Hit beta-1 and you get what we call positive chronotropic effects.
Faster heart rate.
Right. And positive inotropic.
Stronger contraction.
Yep. And positive dromotropic effects. That's increased speed of electrical conduction through the heart. So it's basically the accelerator pedal for the heart. Also increases renin secretion from the kidney, which plays into blood pressure too.
Got it. Beta-1 heart accelerator. What about beta-2?
Beta-2 receptors are, well, they're different. Found in the smooth muscle. Think bronchioles in the lungs, arterioles and skeletal muscle, even the uterus and GI tract. Beta-2 is the relaxation receptor. Stimulating it causes bronchodilation, opening the airways. Crucial for asthma, obviously. Also relaxes uterine and GI smooth muscle, and it triggers glycogenolysis, releasing glucose.
Okay, so beta-1 speeds the heart, beta-2 relaxes airways and other smooth muscles. And you mentioned a third type, the VIP receptor.
Ah, yes, the dopaminergic receptors. These are unique. They're only stimulated by dopamine itself. Activating these causes dilation, but only in specific blood vessels. Renal, mesenteric, coronary, and cerebral arteries. The idea is to improve blood flow to those vital organs, especially the kidneys.
That receptor map is key then. Alpha constricts, beta-1 hits the heart, beta-2 relaxes airways, and dopaminergic helps vital organ blood flow.
Exactly. And understanding that map lets us understand how these drugs actually work, their mechanism of action. Adrenergic drugs don't just bind, they work in, well, three main ways. They can be direct-acting, like epinephrine. It binds straight onto the receptor and causes a response. Simple.
Okay, direct binding. What else?
Then there's indirect acting. These drugs don't bind their receptor themselves. Instead, they cause the release of the body's own stored catecholamines, like norepinephrine, from the nerve endings. Think amphetamine-like drugs. They work this way.
Ah, so they make the body release its own adrenaline-like stuff.
Precisely. And the third way is mixed acting. These do both. They bind directly and cause the release of stored catecholamines. Ephedrine is a classic example.
Direct, indirect, or both. Got it. And you mentioned something about structure, non-catecholamines.
Right. So drugs like phenylephrine or albuterol, they aren't catecholamines structurally. This makes them more stable metabolically. They don't get broken down as quickly as, say, epinephrine. The practical result, they have a significantly longer duration of action. They stick around longer.
Longer action. Okay, that makes sense.
And this all leads us right into selectivity. This is a really key concept in practice. The source material really stresses this. Selectivity is relative. It's not absolute. No drug hits only one receptor type perfectly, especially at higher doses. And the classic example, the poster child for this, is dopamine.
Ah, dopamine. Right. You mentioned its unique receptors, but the dose really changes things, doesn't it?
It changes everything. It's fascinating and, frankly, a bit terrifying. If you give dopamine at a low dose, say 0.5 to 2 micrograms per kilogram per minute, you're primarily hitting those dopaminergic receptors, so you get that desired effect. Improved blood flow to the kidneys, gut, brain, heart.
Okay, low dose kidney protection, essentially.
Essentially, yes, but increase that dose just slightly into the moderate range, maybe 2 to 4 millipilogrammin. Now the drug's preference shifts. The beta-1 effect starts to dominate. So now you're improving cardiac contractility, making the heart beat stronger.
So moderate dose shifts to beta-1 heart effects.
Yeah.
Okay, and what happens if you push it even higher?
Right. Here's where it gets really, really different. Push that dose way up high dose, maybe 20, 30 milli-T/kg or more. Now you've pretty much fully activated the alpha-1 receptors. The effect: intense, generalized vasoconstriction, clamping down those peripheral vessels.
Wow. So you go from helping kidney blood flow to
Yeah.
boosting the heart to just widespread clamping down, all based on the infusion rate.
Exactly. That extreme dose dependence is why these drugs, especially dopamine and other vasoactive agents, require continuous titration. You need an IV pump for precise control, and you need frequent, close monitoring of vital signs, ECG, urine output, everything. It's non-negotiable.
Absolutely non-negotiable. Okay, since we're talking high alert meds, let's zoom in on that main clinical class you mentioned.
Right, the vasoactive sympathomimetics. These are often called pressors or inotropes. These are the heavy hitters we use in really critical situations like shock and acute cardiac failure.
Okay, let's run through some key ones. Maybe start with dobutamine.
Good place to start. Dobutamine is beta-1 selective, mostly, so its main job is to increase cardiac contractility and output. It's a positive inotrope, used mainly for cardiac failure, especially when you want to boost the heart without drastically increasing peripheral vascular resistance. And importantly, it's only given via continuous IV infusion.
Okay, dobutamine for heart failure, primarily beta-1, IV only. What about the big one, epinephrine?
Ah, epinephrine, the classic. It's the prototypical non-selective agonist. Hits alpha-1, beta-1, and beta-2 receptors. It's the go-to emergency drug, right? Anaphylaxis, cardiac arrest. At lower doses, you primarily see the beta effects. Beta-1 stimulating the heart, beta-2 dilating the bronchioles. But at higher doses, the alpha-1 effects take over that massive vasoconstriction, leading to blood pressure elevation.
And epinephrine brings up a huge safety point, doesn't it? About the labeling.
Oh, absolutely. Critical safety highlight here. You used to see epi concentrations written as ratios, like 1.100 or 1 and 1,000. But this led to absolutely life-threatening dosing errors, just tragic mix-ups. So now regulatory bodies mandate it must be labeled clearly by concentration in milligrams per milliliter, usually 1 milligml or the more dilute 0.1 milligml. This change is purely about preventing those devastating errors at the bedside. Cannot stress that enough.
So important. Okay, epi is non-selective. What about something more focused on just squeezing vessels?
That would be norepinephrine, brand name Livafed. Nora predominantly stimulates alpha receptors, so strong vasoconstriction. It does have some beta-1 effect on the heart, but crucially, virtually no beta-2 effect on the lungs. This makes it a powerhouse for raising blood pressure in profound hypotension and shock, often a first-line pressor.
Levafed, the go-to pressor.
Okay.
And then there's phenylephrine. Sounds similar.
It does sound similar, and that's another safety point we'll touch on. Phenylephrine, brand name neosynephrine. This one is almost exclusively an alpha-1 adrenergic agonist, pure vasoconstriction, used entirely to raise blood pressure by clamping down vessels.
So Norp is mostly alpha with a bit of beta-1 heart effect, while phenylephrine is pretty much pure alpha squeeze.
Exactly. And the clinical pearl here, the thing you must remember is don't confuse them. Norep for norepinephrine Livafed and neosynephrine for phenylephrine. They sound alike. They're often ordered in similar critical situations. They're both powerful pressors. It's so easy to grab the wrong one if you're rushing or not carefully checking the label and the order. Always do your 5 rights meticulously.
Good morning.
Yeah.
Okay, this is the big IV players. What about some outliers? Midodrine. That one's oral, right?
Correct. Mydriatics is interesting. It's actually a prodrug. You take it orally, and it gets converted in the body to its active form, disglamidodrine. That active form stimulates alpha-1 receptors, causing peripheral vasoconstriction. Its main use is for symptomatic orthostatic hypotension people whose blood pressure drops significantly when they stand up, causing dizziness or fainting.
Orthostatic hypotension. And you mentioned something about its timing being critical.
Yes, absolutely critical pharmacokinetics here. Mydriatics has a relatively long duration of action, maybe 6 to 8 hours. Because it causes systemic vasoconstriction, you must advise patients not to take their last dose too late in the day. The rule of thumb is generally no doses after 6 p.m. or at least 4 hours before bedtime.
Why? What?
If they take it and then lie down to sleep, that systemic vasoconstriction doesn't just go away. It can cause potentially severe supine hypertension, dangerously high blood pressure while they're lying flat. Very risky.
Wow, okay, so timing is everything with midodrine. Last one on our list, mirabegron. Sounds different.
It is different. Mirabegron, brand name Myrbetriq, is a beta-3 agonist. This represents a newer mechanism, primarily used for overactive bladder, OAB. By stimulating beta-3 receptors in the bladder's detrusor muscle, it causes that muscle to relax. This relaxation increases the bladder's capacity to store urine during the filling phase.
Interesting. Beta-3 for OAB. Okay, so we've covered the main vasoactive drugs and a couple of others. What about the downsides, the adverse effects?
Well, as powerful as these drugs are therapeutically, you absolutely have to anticipate the adverse effects. And really, they're often just an overextension of the intended effects, simply too much sympathetic nervous system stimulation.
Makes sense. So what kind of things do we see with, say, alpha stimulation?
With alpha adverse effects, you often see CNS issues first. Headache, restlessness, maybe excitement, insomnia can make people feel quite jittery. Cardiovascularly, the big ones are hypertension, obviously, chest pain, and sometimes, perhaps counterintuitively, reflexive bradycardia.
Wait, slow heart rate from a stimulant.
Yeah, it seems odd, but think about it. If the alpha stimulation causes really intense vasoconstriction, the blood pressure shoots way up. The body has baroreceptors that sense this dangerous pressure spike, and they trigger a compensatory response via the parasympathetic system to try and slow the heart rate down, to protect itself.
The body trying to compensate for the drug's effect. Got it. What about beta adverse effects?
Beta effects are kind of what you'd expect from stimulating the heart and CNS side. Mild tremors, nervousness, maybe some dizziness, cardiovascular, increased heart rate, that positive chronotropy, palpitations, and potentially dysrhythmias. An overexcited heart can get electrically unstable.
Okay, so overstimulation effects. What happens in actual toxicity, like an overdose?
Toxicity management is often supportive, primarily because many of these drugs, especially the IV ones like epi and norepi, have very short half-lives. So if you stop the infusion, the effects usually start to wear off relatively quickly. However, the two most life-threatening consequences involve the CNS think seizures from overstimulation and the cardiovascular system. Specifically, the risk of intracranial bleeding from extreme hypertension is a major concern.
Seizures and brain bleeds. Okay, serious stuff. How do you manage that severe hypertension if it happens?
If the hypertension is truly severe and dangerous, the key intervention is often to administer a rapid-acting sympathetic drug, something that blocks the adrenergic effects. A common choice is an IV beta blocker like esmolol, which works very quickly to counteract the excessive stimulation.
Got it. Reverse the effect quickly. Any major drug interactions we need to flag?
Oh, definitely. The classic major interaction alert is with MAOIs, monoamine oxidase inhibitors. Combining MAOIs with Badgener drugs can lead to a massive release of catecholamines and potentially cause a life-threatening hypertensive crisis. Absolutely avoid this combination. And of course, adrenergic antagonist drugs that block these receptors, like many antihypertensives, will naturally antagonize or reduce the effects of these adrenergic agonists.
MAOI interaction is the big one to remember. Okay, let's pull this all back to the nursing process. Where does the nurse really make the difference here?
Well, it starts, as always, with assessment. Phase 1, you need a really thorough patient history. Any cardiovascular problems, renal or liver function issues, allergies, current meds. Then focus on baseline monitoring. Vital signs are critical: BP, heart rate, rhythm, respiratory rate, oxygen saturation. Auscultate breath sounds, heart sounds, get that baseline. And specifically for patients starting midodrine, you absolutely must assess postural blood pressures. Check BP and heart rate supine, then sitting, then standing. Document any drop and any symptoms like dizziness. This is key for monitoring effectiveness and safety.
Right, thorough assessment first, then implementation. This is where safety really comes into play, especially with those IV vasoactives.
Absolutely. These drugs, except midodrine, are incredibly potent and fast-acting. They demand careful administration. Always use an IV infusion pump for precise control. Titrate the dose based on the patient's response and the specific orders. And constant monitoring is essential: continuous ECG, frequent vital signs, often an arterial line for real-time BP monitoring in critical care.
And you mentioned dopamine earlier. Is there a reason it might be preferred in shock sometimes?
Yes, that dose selectivity comes back into play. When managing shock, dopamine at those moderate doses, hitting beta-1 and dopaminergic receptors, is often liked because it can help raise blood pressure and improve cardiac output while also potentially improving renal perfusion. This is sometimes seen as an advantage over a drug like high-dose epinephrine, which causes intense vasoconstriction everywhere, potentially including the kidneys, which might worsen renal function.
So dopamine offers that potential kidney-sparing effect at the right dose. But what about the Hy-Vee site itself? That seems like a huge risk area.
huge. Possibly the single most critical safety measure for administering 5e vasoactive drugs, especially potent vasoconstrictors like norepinephrine, phenylephrine, and high-dose dopamine, is preventing extravasation.
Extravasation, the drug leaking out of the vein into the surrounding tissue.
Exactly. Because these drugs cause such intense local vasoconstriction, if they leak out, they can clamp down the blood vessels in that tissue so tightly that the tissue dies. Severe tissue necrosis. It's devastating. This means you must check that IV site meticulously and frequently. Some protocols say every hour or even more often. Look for any signs of infiltration, swelling, coolness, pain, blanching, redness later on.
And if it happens, if
Yep.
you suspect infiltration,
Stop the infusion immediately. Leave the 5e cannula in place initially. Try to aspirate any residual drug and notify the physician's stat. There's an antidote, phentolamine. It's an alpha blocker that counteracts the vasoconstriction. It needs to be injected into the area of infiltration as quickly as possible to restore blood flow and prevent tissue death. Every unit that uses these drugs needs a clear extravasation protocol and needs phentolamine readily accessible.
that risk was highlighted in a case study, wasn't it?
Yes, the text mentions the Macon-Bibb County Hospital Authority versus Ross case. It's a stark reminder. In that case, there was a significant delay in recognizing and treating a dopamine extravasation. The delay in notifying the physician and initiating treatment led to permanent injury and significant liability for the hospital and staff. It underscores the absolute necessity of frequent site checks, prompt action, and also the importance of using large, stable veins, preferably central lines if possible, for infusing these potent drugs. Failure here is negligence.
A very sobering reminder. Okay, one last piece.
Uh-huh.
Patient education. What's a key take-home for the learner about teaching patients?
Couple of key things. For patients using inhaled adrenergic agonists, like beta-2 agonists for asthma, albuterol, etc., they must use them only as prescribed. Overuse can lead to loss of effectiveness and also those systemic side effects we talked about, tremors, nervousness, increased heart rate. Also, if a patient is prescribed 2 different inhaled medications, say a bronchodilator like albuterol and an inhaled corticosteroid,
Which one goes first?
the bronchodilator always goes first. Use the beta-2 agonist, wait about 5 minutes, then use the corticosteroid inhaler. The logic is simple. Open up the airways first with the bronchodilator so the anti-inflammatory corticosteroid can get down deeper into the lungs where it needs to work.
Bronchodilator first, wait 5, then steroid.
Got it.
And for midodrine.
Reinforce that timing rule.
Yeah.
Take it early in the day, don't double up doses, and absolutely no doses within 4 hours of bedtime to prevent that dangerous supine hypertension.
Excellent. Okay, let's try and synthesize this.
All right, so adrenergic drugs, or sympathomimetics, are incredibly powerful tools. They essentially let us harness the body's own fight-or-flight response. Understanding that receptor map alpha, beta-1, beta-2, dopaminergic, and the fundamental principle that dose often dictates selectivity is absolutely the key. That understanding is the foundation for safe, effective clinical use, letting you predict effects and anticipate problems.
Right, so for you, the learner, you now have a solid framework. When you encounter any adrenergic agonist, you can start to analyze it. What receptors does it hit? What's the expected therapeutic action? What are the most likely adverse effects, like that risk of supine hypertension with midodrine? And what are those crucial safety checkpoints, like meticulous HAV site monitoring for extravasation, or using the correct epiconcentration, or ensuring proper titration of dopamine?
Exactly. It gives you the power to anticipate and act safely.
Okay, so here's a final provocative thought for you to consider, building on what we've discussed. We talked a lot about the complexity of the sympathetic nervous system and how drugs like dopamine show extreme dose selectivity, moving from low dose protecting the kidneys to moderate dose boosting the heart to high dose causing massive peripheral vasoconstriction. It's almost like shifting from one life-saving goal to its potential opposite, with just small changes in rate. So how does truly understanding this extreme dose selectivity, this knife-edge balance, influence your critical thinking and your sense of responsibility when you were the one at the bedside titrating these life-saving but potentially dangerous medications?